These illustrations show different types of hiatus hernia. On the left is the sliding hernia. Remember that only the anterior surface is covered by peritoneum, while the posterior surface is retroperitoneal. The second picture is the sliding hernia, the sliding hiatus hernia, in which the part of the fundus slides beside the esophagus into the thorax. And the last picture is mixed one. Clinically, it presents with most cases present with picture of GERD disease, heartburn and regurgitation. The complications of the initial GERD disease, first esophagitis. The first stage is esophagitis. When the endoscopist reports in his report that in addition to documenting the hiatus hernia and reflux disease, if he says there is esophagitis, we should pay more attention to this patient. Esophagitis, if untreated, will progress to ulceration, which might bleed, and if not treated, it might lead to stricture formation. Epigastric pain, lower chest pain, palpitation and hiccups from the pressure effect of this sliding hernia on the thoracic organs. So pressure on the heart may precipitate palpitation, and on the diaphragm precipitate hiccup. Hiccups is a sudden contraction of the diaphragm, which might be very distressing sometimes if it is unresolving. The paraesophageal hernia, in its complete picture, can progress to complete volvulus of the stomach in the chest, which is at risk of strangulation and should be operated on emergency basis. Treatment is the treatment of GERD. Achalasia. Achalasia is a functional disorder of the whole esophagus. The main problem with these patients is failure of relaxation of the lower esophageal sphincter, which produce an obstruction. It's not an anatomical obstruction, but it is a functional obstruction. Failure of the lower esophageal sphincter to relax. So to be obstructed lower esophagus, which will end with dilatation of the esophagus above this stenosed part or narrow part. The cause of this is a partial or complete degeneration of the mentoric plexus of our bowels. So there are no enteric nerve supply anymore to initiate the peristalsis and the relaxation of the lower esophageal sphincter. It will end with complete loss of the dorsal vagal nuclei, as demonstrated in these patients. There are parasitic disease found in South America, which mimics this picture by the protozoa Trypanosoma cruzi. It's called Chagas disease. It's end with destruction of these mentoric plexus, which will lead to a picture similar to achalasia. Sometimes the tumors of the lower esophagus can mimic for some time the picture of achalasia, but soon diagnosed by endoscopy. It affects 1 in 100,000 of population in developed countries. The patient is in the middle age, 30 to 40 years old. Females are more affected in the ratio of 3 to 2. It presents with progressive dysphagia over years. We said that cancer has dysphagia rapidly progressive over weeks, here over years, and sometimes with some remissions and recurrence. It's greater for liquids more than solids, opposite the obstruction of carcinoma. And sometimes it presents with pain, retrosternal pain. Weight loss, halitosis, because of the accumulation and fermentation of this accumulated food above the stenosed lower esophagus. Regurgitation sometimes can lead to aspiration and pneumonia. On the long term, achalasia can predispose to squamous cell carcinoma of the esophagus. This is the contrast study which shows what is called inverted bird beak appearance. مثل منقار الطير, the stenosed area of the lower esophagus and dilatation of the esophagus above this area. Management. Management can be by balloon dilatation of the lower esophageal sphincter or by surgery. Surgical myotomy. It's called Hiller's myotomy. This operation is done by division of the muscular layer around the lower esophagus and the upper proximal stomach. It's like the Ramstead operation of the pyloric stenosis. You know Ramstead operation? Some infants has this pyloric stenosis due to hypertrophy of the pyloric muscle. We treat by cutting this circular muscle to relieve this obstruction and budging of mucosa. It's done in the same way, but here it's more critical because the esophagus is more fragile and has no serosa, so there is always a risk of perforation. We have to pay attention while doing this operation. This is the Hiller's myotomy, dividing the lower 5 centimeter esophagus muscles until the mucosa bulge, and we extend our incision 3 centimeter down the stomach. This lower part is a bit more difficult because the muscle fibers are not so regular as they are in the lower esophagus. It becomes oblique, so the surgeon should pay more attention to avoid perforation here while doing his myotomy. So the most important complication is perforation, which should be managed in the operation and repaired. Late complications is the reflux, because there are no more sphincter in the lower esophagus. We relieved the obstruction, but we resulted in some reflux. Reflux can be tolerated much more better than the obstruction of achalasia. And recurrence is one of the complications. If the Hiller's myotomy is not complete, the residual muscle fibers might cause again obstruction, inadequate myotomy. We like to add to this myotomy a fundoplication, a simple fundoplication operation to avoid reflux, because the reflux is almost certain after this myotomy. So we add this fundoplication to decrease the degree of reflux disease. Another advantage of this dorsiflication, when we do accidental perforation of the mucosa while doing the myotomy, this dose fundoplication will help us to cover the mucosa, and probably we feel more comfortable by covering the perforated repaired mucosa. we simply pull part of the fundus of the stomach to the other part, the right side of the myotomy, to cover this gap. The studies which compares the surgical myotomy to balloon dilatation did not find significant difference. These are some rare pathologies of the esophagus. Diffuse spasm of the esophagus found in middle-aged and elderly patients. It presents with intermittent dysphagia and retrosternal pain. It is caused by repetitive irregular peristalsis of the esophageal body, which makes this ineffective peristalsis and painful contraction. Esophageal manometry is the way to diagnose this pathology. It can be precipitated by GERD disease. The surgical treatment is long myotomy, the same as we do for the lower esophagus, but this time we will extend it to the whole esophagus to relieve this severe spasm. The results, unfortunately, are unpredictable. Some patients improve, some patients not. Most patients are treated with medical treatment by nitroglycerin and calcium channel blockers, which will relieve the spasm a bit. And PPIs, of course. Nutcracker esophagus, another rare disease which is caused by a repetitive, very forceful peristalsis, which can result in an intraluminal pressure of 150 millimeter mercury. Remember earlier we talked about the normal peristaltic movement of the esophagus, which results in intraluminal pressure of, مين ذكرنا بالرقم؟ قلت لكم remember this number. 80. Good. 80. So now we have doubled this intraluminal pressure, which makes this contraction ineffective for swallowing and painful. The treatment is difficult. There is no effective treatment for this condition, unfortunately. Surgical myotomy has poor results, dilatation has poor results, and sometimes is treated medically with nitroglycerin as the diffuse esophageal spasm. Pouches are herniations of the esophageal mucosa through the muscular wall of the esophagus. The most common one is Zinker's diverticulum. It is resulting from a spasm of or a raised cricopharyngeal pressure. This increased, the cricopharyngeal is the upper esophageal sphincter. In these cases, it has very high pressure, which results in this herniation. The herniation is usually posterior, but it deviates to one of the sides, usually the left, because of the vertebral column. It presents with dysphagia and feeling of obstruction in the upper esophagus. There are some other pouches in the chest also around the tracheobronchial tree. Just above the gastroesophageal junction, if there is a raised pressure in this like achalasia, it can result in also some pouches there. The presentation, obstruction, dysphagia, and halitosis due to fermentation of residual food there, regurgitation, and sometimes end with aspiration and pneumonia. Lump in the neck can be palpable. And in some cases, it's completely asymptomatic. Contrast study which shows will show the diverticulum, the pouch, and endoscopy confirms the findings, and but should be done carefully to avoid any perforation. Treatment is by surgical myotomy of the cricopharyngeus and excision of the pouch. Now it's done with the stapling, endoscopic stapling, which opens both cavities together in one cavity, and at the same time divides the cricopharyngeal sphincter. So we put a stapler through the mouth, one limb in the esophagus, one limb in the pouch, and fire. This will open these two cavities together and divide the sphincter. Perforation. Perforation of the esophagus is a serious event. We should always be anticipating this to manage immediately, otherwise it will have a high mortality. What can cause perforation? From inside the esophagus by a sharp foreign body. If somebody swallowed a sharp foreign body, child for example, it can result in perforation. The usual sites are the sites of anatomical narrowing of the esophagus. The commonest cause of perforation is iatrogenic, by doing endoscopic procedures. Before, in the era of solid endoscope, it was more common. Now with fiber optic scopes, it's rare. But during procedures, it still can happen. The most common of them is dilatation. When you are going to dilate a stricture, for example, you always have the risk of perforation. So you should observe for this perforation. From outside the esophageal wall, a stab wound, penetrating knife injury, for example, in the neck. Some cases of spontaneous perforation was called Boerhaave syndrome by violent vomiting. It will result in tear of the esophageal wall. Usually the mucosa. There is another condition of perforation called Mallory Weiss. Now before we are talking about complete perforation of the esophagus. This Mallory Weiss is just tear of the mucosa. It's not complete full thickness perforation, but it will present with bleeding, with pain. The clinical picture of esophageal perforation depends on the site of perforation. Most serious in the chest. The perforation in the cervical region usually will present with pain and surgical emphysema. You will feel air in the neck tissues. While the thoracic esophagus, which is the most serious, it will present with severe retrosternal pain, sometimes with shortness of breath, and if it is severe, with shock, complete shock. Perforation of the abdominal esophagus will end with peritonitis. Chest X-ray will diagnose this perforation by showing the mediastinal emphysema. We will see a rim of air around the mediastinum. Mediastinal emphysema, mostly it indicates perforation of the esophagus. The confirmation is by CT scan. Usually we ask immediately if there is any suspicion of esophageal perforation, we should ask for CT with contrast. of course, IV and oral contrast. Then we can see the exact point of perforation and the magnitude of this perforation. If it is limited, very small perforation, we can treat conservatively by keeping the patient in PO and putting him on strong IV antibiotics and antifungal also. This is the CT scan. So management, the cervical esophagus, most cases are treated non-operatively, keeping the patient in PO and giving him antibiotics until it heals. The thoracic perforation, which has the higher morbidity and mortality, small perforations can be treated conservatively, non-operatively, but when the perforation is big, it needs operative treatment or surgical interference. And then according to the pathology, it is managed according to the magnitude and size of perforation, but generally speaking, these cases are difficult to treat and has high mortality and morbidity. Tumors of the esophagus. Benign tumor of the esophagus are rare. Leiomyoma of the esophagus can be treated by inoculation, simple inoculation. The carcinoma is the common tumor. The incidence about 15 in 100,000. Male to female, 3 to 1 ratio. In the Far East, there are more commonly seen cases of squamous cell carcinoma. Nowadays, 2/3 of the carcinoma of the esophagus is in the lower 1/3, which possibly follows Barrett's esophagus, and the remaining are on the upper 2/3, predominantly squamous cell carcinoma. This part of the cancer esophagus, of the lower 1/3, adenocarcinoma following Barrett's dysplasia, is increasing with time over the original esophageal disease of squamous cell carcinoma of the upper 2/3. The risk factors is the reflux disease. This is the main risk factor for adenocarcinoma. For squamous cell carcinoma, it is in the literature described a lot of risk factors like alcohol, smoking, leukoplakia, achalasia itself, eating salted fish, and chewing tobacco, etc. Corrosive injuries sometimes are associated with squamous cell carcinoma. The spread of the tumor is by 3 ways: direct invasion across the wall, or longitudinally in the submucosal lymphatics, or hematogenously to the liver, lung, etc. Clinically, it presents with progressive dysphagia to solids and then to liquids later, regurgitation and weight loss. This is why we should pay attention to weight loss always, unintentional weight loss. Sometimes there is odynophagia because of the involvement of local nerves, painful swallowing. These are signs of metastatic disease, unfortunately. Hoarseness of voice, involvement of the carotid nerve. Horner syndrome, involvement of the sympathetic chain. Horner syndrome, meiosis, ptosis, and anhidrosis. In average, the patient presents with history of 3 to 9 months of symptoms before presentation. This is why most of them are late and unfortunately are not for curative treatment. Investigation, the barium or any contrast swallow will show the anatomical picture exactly, and it allows biopsy. The endoscopy is the better investigation, and it allows biopsy. Also, we investigate the patient for metastatic disease like CT scan and PET scan, and blood tests to show any anemia or liver dysfunction. If the lung respiratory complications happen, we can do also bronchoscopy. Management, the radical treatment is the esophagectomy, the surgery. But unfortunately, as I said before, most of the cases are presenting late. The overall 5-year survival is less than 10%. Although some studies shows a better rate when the patients present earlier and they are managed in a high volume centers. Multimodal therapy is required. The surgeon, the oncologist, the nutrition, etc. All the team should be part of this treatment. The surgical resection is available for a few patients only, unfortunately. Palliative esophagectomy is not preferred anymore because of the high morbidity and mortality and the availability of stents. The main operation of the esophagus is the resection of the esophagus in a two-stage esophagectomy. It's called Ivor-Lewis operation. Laparotomy first to mobilize the stomach on the vascular pedicles of the right gastric and right gastroepiploic, while the left gastric and the left gastroepiploic is sacrificed to be able to mobilize the stomach and pull it to the stomach. Then we will do, after that, right thoracotomy to mobilize the esophagus and resect it and pull up the mobilized esophagus, mobilize the stomach into the esophagus and anastomose the mobilized stomach to the upper esophagus. This illustration shows the operation of Ivor-Lewis. The other approach is left thoracolaparotomy in one incision, left thoracolaparotomy, when the tumor is at the esophageal-gastric junction. If the tumor is upper, we cannot have this approach because of the aortic arch. The last approach is the transhiatal esophagectomy. It's done by mobilizing the stomach and lower esophagus from the abdomen, and then mobilize the upper esophagus and the rest of the esophagus from the neck through a cervical, left cervical incision. After complete mobilization, we can pull up the stomach tube with the esophagus to the neck and resect it and anastomose the tumor tube, stomach tube to the upper esophagus. The recovery of these patients after this operation should be by teamwork with a multidisciplinary team. The feeding is an important part, the early feeding of these patients. This is why some surgeons do feeding jejunostomy at the same time to help in early enteral feeding. Locally advanced tumors can be considered for pre-operative chemotherapy. Start chemotherapy before operation, then we do the surgery, and after that we can complete the chemotherapy. Sometimes the radiotherapy is added also to these patients, pre-op and post-op, especially in squamous cell carcinoma. Remember, the squamous cell carcinoma is a radiosensitive tumor which responds very well to radiation, but not the adenocarcinoma. Some cases end with complete resolution of the tumor with radiation. And when they resected the specimen, the histopathology showed no residual tumor. Most of the patients are treated palliatively, unfortunately, but palliative treatment only because there are no chance for curative treatment in these late cases. The most successful palliation is the self-expanding metal stent. This is why we are not doing any palliative esophagectomy anymore, except in very little cases. This stent will result in good palliation to dysphagia. Palliative chemotherapy can also improve the symptoms and increase the life expectancy. Palliative radiotherapy is best done by direct intraluminous radiation, which is called brachytherapy, but unfortunately it's not widely available. So most of the cases are treated with external beam radiation. In summary, don't ever neglect dysphagia. Dysphagia always should be investigated. GERD and Barrett's esophagus are associated with adenocarcinoma of the lower esophagus. Early diagnosis is the most important thing to allow curative treatment. Late diagnosis results in poor prognosis. Curative treatment is multimodal, multidisciplinary team. Surgical outcome is better in high volume centers. Cancer esophagus should be operated in specialized centers, not by a surgeon who is doing a case every 5 years. شكرا. نكمل رأسا الثاني ولا بدكم تستريحوا شوي؟
عشانك دكتور عشان تستريح.